we are willing to use every resource possible that we have to help you. And so partner with us. We're in this together.
Hello, and welcome to Your Health Matters. I am your host, Vivian Nacho Ayok, certified diabetes care and education specialist, pharmacist, and founder of Surrogate. So, we started things off with diabetes, and today's episode is focused on primary care providers or healthcare providers in general. We're going to have a great conversation around the challenges they experience managing this condition out in the field. So, joining us for this conversation today, something really important we have to address is Dr. Gilbert Daniel and Miss Gwendolyn Daniel-Challenger. Welcome to the show, guys.
Thank you, Vivian.
Thank you,
It's
Vivian.
really
Good to be here.
awesome. I know when we talked about this and you guys agreed to join us, I was just super, super happy. You guys are just the best. So, can you share with our listeners a little bit about you, how long you've been in practice, and all that good stuff? So, Ms. Gwen Daniel Challenger, you want to go first?
Okay, so my name is Gwen Daniel-Challenger, and I'm a physician assistant working with my brother, Dr. Daniel, in Southeast DC. I've been there for the past 12 years working with him. Prior to this, I worked in New York for about 13 years in primary care also and pediatrics. And it's been a pleasure now working in Southeast DC. I love the demographics. I wouldn't do this anywhere else but where I am. That's how much I love it. So it's just a pleasure to work with them and to be part of this discussion today.
I'm Dr. Gilbert Daniel, and I'm a graduate of Howard University College of Medicine, also a graduate of Howard University internal medicine program. And I've been working here in Southeast Washington, D.C. now since 2005, actually August 1, 2005, as a hospitalist initially, and I started primary care in 2007 here in Southeast, which is where I've been since. There's no better place to be. I don't think I'll do this any other place. We've met so many people, so many great patients, so much experience, so many stories, so many people with different chronic conditions, but this is the place to be.
Love it. Thank you so much. You have your own business in Southeast, am I correct?
Yes, our primary care practice is accent, which is my accent, which is a focus. The accent is a focus on health. So it's accent on health. We are located at the formerly Greater Southeast Hospital, now United Medical Center, in the medical building, 1328 Southern Avenue. We're in suite number 205 here in Southeast.
We in DC talking about some of the challenges you experience out in the community. And I know DC's matches the national statistics in terms of diabetes. I think it's around 9%. But the community that you serve, that's in the double digit. Is that the same thing you're seeing as well in your practice?
I think that's about correct, Ms. Vivian. I think we're about 11, probably 11, 10, 11%, Gwen. But I
Yeah.
know we are probably on the higher side, and for the district's average, I think that's where we fall.
Just walk us through that process of someone, for example, newly diagnosed, they come in for an appointment. What does that normally look like from your end in clinic? Breaking that news to them, making sure they have the resources they need. Can you walk us through that process?
Well, initially, when someone is diagnosed with diabetes, for them, it's an overwhelming experience. Patients normally think of the worst that they've heard about diabetes. They've heard about people being on dialysis, which is kidney failure. They've heard about people losing a limb, losing one toe, two toes, one foot, both feet. And so they normally basically gravitate towards the worst that they've heard and they've seen. And so the focus is on getting the patient calm enough to understand the disease of diabetes, what it is, how it affects them, and learning the basic things about diabetes, their numbers, what does a number represent when we take the blood glucose? What is the number saying? Why do you have diabetes? And then once we've calmed the patient sufficiently, then we can actually begin to work with the patient. And now what do we do? How do we move from here? What do we do with the numbers we have? What do we do with the diagnosis we have? And reassuring the patient diabetes is controllable. This is not a disease that's going to wipe you out, send you to the dialysis chair, or hopping on one foot tomorrow, or doesn't even have to be at all. If we work together to help manage the disease and letting them know the importance of the provider's role and their role, family role. And often, actually, I haven't seen one patient after leaving the office who's not really, reassured and basically feeling that they can do this. They're asking questions like, so what should I do next? What do I do next? How often do I need to come see you? What happens if my number is this? What happens? So one of the things it does, it helps to develop a very good relationship with the patient because these patients know they need to be seen a little bit more often. They usually have lots of questions to answer. It's an opportunity also to give them printed information to help them that they can take home. Sometimes we have diabetic plates in the office, portion size plates we give them so they can know what a meal portion should look like, tangible things to show them. And so it's quite a long visit, actually, having to discuss the diagnosis, the disease, and help them plan forward. I've never seen a patient actually who's left feeling defeated. Oftentimes, actually, they've left feeling motivated that this is something with us together that they can manage and manage well.
And what Gwen has said, because we are in the treadmill medicine, everybody has 15 minutes. The providers, you have 15 minutes, and then you're on to the next one. And everybody is very impatient. Not everybody, but so many people are so impatient. But these are the patients now who we actually have to take a lot more time with. So we sit them down, we calm them down, and we also let them know that behind us, not just us as the providers, we have diabetic educators, and we have one of the best here who comes to our office and provide that part of the management to the patient, who can break things down, show them actually what they're eating, why the sugar is high, and then we also reassure these patients that they can actually walk in at any time if they have any problems, because invariably these patients, their blood sugar would spike high, sometimes low, and of course that's a very anxious moment, and these patients need reassurance. So we allow them to come in. Just walk in when you have a problem. You may have to wait a little, but you will get the care that you need. You will be attended to, and you will be happy.
I am so grateful to hear that. And that, I think not every patient would say that's been their experience so far. But I know you two, and I've worked with you guys, and it's been such an amazing experience, which is why we collaborated in the first place, was because we recognized that people needed a little bit more in terms of managing a condition like diabetes. Now, you've given them some information from the doctor's office. You let them know they can always schedule appointments and come in and even walk ins. But what about resources that's available? You talked about the plate method and other things. But when they go out in the community, do you feel like people really have access to the resources, especially nutrition, physical activity, and other things, to begin to really make that lifestyle change?
I think down here, especially in our area where we are in Southeast, which has been designated as one of the food deserts in DC, there's a lack of basically fresh green vegetables and fruits, a deficiency. You got to focus on drinking more water. So now they have to figure out a place where they can. So instead of buying sodas, now you have to be buying water. Now you have to get to the grocery store. So yes, there are challenges in terms of the resources, community resources, just in terms of the diet and what's available to them. But like I said, with reassurance, we are able to manage as best we can. And we are able to help these patients quite a bit.
Ms. Gwen, I know Ms. Gwen Challenger, you normally would refer them out to a diabetes educator. We even talked about opportunities for nutrition support. Gwen, can you share a little bit more about the resources and how you're able to connect your patients to diabetes education programs? To add on to what Dr. Daniel shared about making sure people have what they need when they get out in the community to do well. I know you've done a really amazing job making sure they have access to that education, but there's other things also that you're doing as part of the visit to make sure that when they're out there home, they can actually have what they need so they can begin to make those lifestyle changes. So you want to share a little bit more about what you guys are doing?
Oh, to piggyback on what Dr. Daniel says, we have the diabetic educator, you, Dr. Vivian, who comes in once a week to help our patients, especially those who are very difficult to manage, poorly controlled diabetics who are having a really hard time getting their blood sugars under control. One of the things that also that they benefit from during this visit is getting the CGM, the continuous glucose monitoring device, placed and getting education about that. And that, for some reason, helps really to empower patients when they know that they have something that, number one, they don't have to prick their fingers. Number two, that they can see their numbers through the day and really learning what triggers their diabetes, what makes the blood sugar go 200 and above. So that's really very helpful because, you must understand that most of our patients, when they think of vegetables, they're thinking of vegetables in cans, canned corn, canned beans, canned peas, canned carrots, which is very low in nutrition. And so that's been one of the things we've had to have discussions about, changing the way our patients view healthy foods. It gets overwhelming, as Dr. Daniel said, considering the time we allotted with each patient.
Thank you for bringing that up. And I think sometimes patients still do say it when they come into our education program that, they've been diagnosed 3, 4 years, and this is their first time actually seeing a diabetes educator to really begin to understand the condition and the small changes that they can make on a daily basis or even weekly basis to begin to improve their numbers. So I'm really grateful that you guys recognize that you need that support and you're actively reaching out to make sure that your patients do get it. Because one of the times when it's really recommended, at diagnosis, and even when people are experiencing complications, that they do and can benefit from having sessions with a diabetes educator. It's really great to see that you guys are already doing that and making it a part of your practice.
I just want to add one more thing here. We have sent a lot of these same patients to diabetic educators before, but the diabetic educators are in different buildings, different places, different sites. And it's really difficult for patients to go someplace when they don't know anyone to just sit down and start talking about what they eat. Nobody really likes to talk about how they eat, what they eat, when they eat. And so having the diabetic educator on site, somebody we trust, is so much easier because we don't get pushback from patients because they said, okay, we wanted to see the diabetic educator to discuss this and that because we're having this issue, the numbers are going up, and let's go talk to someone and let's go get some meal planning. It's so much easier. And so I could understand when you say that the patient said they've been diagnosed for 4 and 5 years and this is the first time they see someone. It's because now it's so much easier. Once you've made contact in the office with that patient, the patient actually can follow up.
The other thing is with the CGM, as we know, we use Freestyle Libre. I mean, I guess I can mention that. That's one of the devices. I know personally for the young men, the gentlemen, those are not so young, who are diabetics, who've been, over the years, we've been trying to get these guys to prick their fingers. I mean, we know in practice, you're not going to get a man pricking them fingers 3 times a day. It's not going to happen.
It does.
If we get 2, we are lucky. So now with the CGMs, and we have and everybody has their smartphones and they can actually see these numbers. I mean, it's night and day. So these guys are actually participating in their care actively. We've been speaking about Vivian here and Sarogi, massive shout out because the ease at which the patients transition from our care when they are referred to you, Vivian, and the way how you deal with them, and when they come back. I mean, all of the stress levels are reduced in these patients. And if you reduce somebody's stress levels and you're educating them, everybody wins. So the patients are so comfortable with you. So when they come back, they're understanding what you're telling them. And now they're going and telling me, man, that potato, I see, no, I don't use that big potato anymore. I can cut that potato in half. I know, because they can actually see their numbers. And it means so much. So we say thank you for that.
Thank you, Dr. Daniel, for agreeing to that approach. I like something you said, that nice warmth in the office, that it builds trust. When you hand that patient out to the diabetes educator, it's right there in the same building. Actually, I'm next door. It makes a big difference because sometimes that trust can make a big difference whether you give someone a referral and they follow up on it or not. But to have it really conveniently located, they trust you already, and that way you hand them off to the diabetes educator. You're making sure that right there, they're already there, present. They are beginning to get the education they need right there in that visit session before they even go home. I think that is really, really great. And it takes also the challenge of transportation. Some things we don't think about. Sometimes it's a struggle for people to get from one place to another. So can you talk a little bit about the importance of having trust, a trusting relationship? Do you think it makes a difference in whether people buy in and work with you as providers towards improving their health?
I can speak to this because I remember starting primary care here when I started working here back in 2007. Most of my patients had my cell phone number because I did not just want these patients to be calling in and, you have a voicemail and you had, somebody on call for you and then somebody sending me the messages to say, okay, call Miss Jones, Dr. Daniel, she has a question. What we did right away, those patients were calling me. When they called the numbers, they were calling me directly. And I'm telling you, that kind of trust that we've been able to build over the years, and I know Gwen is the same. Some of these patients, the patients who need care and who are a little bit more anxious about what's necessary. Say, look, just call me anytime. Can I call you Dr. Daniel? Today's Sunday. No, it's okay. Just leave a message and I'll get back with you. So we've built that trust over the years and working here in Southeast, and we have found by building that trust, it's been able to help us and help those patients manage so much so that when we are referring these patients to a diabetic educator, it's not like I'm giving you away to somebody else. We're still here. I'm just asking you for some help, which is necessary. There's something else that's necessary here for your management, for your treatment, for your care, for your family. So I'm giving you these additional resources. The diabetic educator, Vivian, she has different resources than I do, and she can help you. And the other thing that I know, Gwen tell them, and I tell them, look, Vivian is next door, we're right here. So if you go in there and you hear something that doesn't make sense to you, and you're upset about, come back over here. You can come back here. But most times when they come back, they're just coming back with thumbs up. Look, I know what I need to do. So, yeah. I mean, that has been critical to our success ongoing, and we planned on building on that as we move forward.
This is built from just showing patients that you care, They don't care what you know until they really know that you care for them. And people know when you care. And so for us, just spending the extra time to hear them, to speak with them, to take their personal phone calls, to listen to their complaints, just taking the time to care. And I think that's what really builds trust. And so from here on, and when we refer them someplace, they know because we care that we won't be referring them to any place that's not good for them. Because patients know.
Oh, they know. They know when you care and when you don't. That's one thing I love about the community we serve. They can tell. They can pick it out right away if someone truly cares for them or not. It is amazing sometimes how quickly they are doing that. So the next question I have has to do with just how medicine has changed over time, the practice. We know that now, Dr. Daniel, you mentioned a 15 minutes appointment. Is it enough? And then electronic health records, we have to document in a certain way. It's really changed, right? From, I'm sure, when you started practicing, Dr. Daniel, to now, what providers have to do. Just talk about that challenge of just meeting the requirements for insurance purposes and how that might be taking time away from you really having that one-on-one and really longer appointments with your patient.
I mean, I remember clearly, and I've told the stories of so many different patients. I think this was in I can almost say January 16, 2012, when we switched to electronic medical records. The day when we switched, the exact day was a Monday, and you can go back and check, but I think that's what it was. It was a Monday, and the day we switched, we scheduled 5 patients for the entire day because it's a training course. It's a massive obstacle course as far as I'm concerned, because I think probably I'm one of those physicians who like, what, I mean, I just detested the whole idea of having to put everything on a computer rather than my own personal chart, right? which I locked in my office. Now it's on the computer and it's out there for everybody to see. But this is where we are now. So I remember that day we scheduled 5 patients, and Gwen, they're younger than me, they picked up this thing much faster than I did, I think, at the time. So I was the slow one. It was Gwen and myself and the trainers who were here. And I was in that room across from where my office is here with one of my 80, I think at the time she was in her 80s, but one of our loyal patients, because we chose patients who are very patient. So that day, as I was there sitting with her in that room, and I had the computer, and the trainers, they said, okay, here we go, Dr. Daniel, check her in right here. Now here, this is a vital sign, just stick that right here. Now you have to input a medication right here, and here's the medical history. And I'm going through the thing, and the lady said, okay, now, you want to take a hit at it? And then she moved on. She probably went to the next room to check on Gwen. And that lady said to me, well, Dr. Daniel, it seems to me like from now on, you're going to be talking to the thing and you forget about me. so, so that was more education for me than anything else. I said, oh, now I see, which we really have to be careful with. So since that day, I mean, that's when I used to take the computer into the patient's room. I don't anymore. I still have my little clipboard,
I know you do have a clipboard and you still do it.
I still do it, and I do it twice. So I write it on my clipboard and then I go later on. So that's what's taking a lot of time. But for me, just because of what that little old lady tell me, because I find myself when I have the computer in front of me, I'm looking there and then I'm, looking over here, looking back here, looking up. That moment in time, I figure is for the patient. So it costs me a lot more time, takes me a lot more time to do my work. And I can't remember this lady's name. I wish I could, but she gave me an education that day that I would never forget.
What about you, Gwen? How does it feel having to care for your patients and really at the same time trying to document everything you have to in the electronic record? Has that been a big barrier in just providing care, especially since we talk about diabetes, a condition that really takes a lot to manage?
It is, and oftentimes, actually, I'm not even able to document all the counseling I do because you end up doing so much. But if you were to stay and document all that, you spend the whole day at the office and you come home and still do work. It's difficult, and for me, that's the benefit of having diabetic educator to help with so much of that, because most of our patients, there are very few patients in the practice, I think, that just have diabetes as their only condition.
Exactly.
Maybe the younger ones, maybe a few younger ones, that's the only thing, diabetes. But most of them, we're dealing with high blood pressure, high cholesterol, arthritis everywhere, atherosclerosis. I mean, some of them have had
COPD,
stroke,
yeah.
they have gout, they have so many other diseases that needs management. And so we would like to do a lot of the counseling, but you really just can't. So it becomes really difficult because patient is not just one thing, they're not just an eye, they're not just a leg or just a heart, they're a whole person. And so still have to ask them about questions. How are you sleeping? Do you have problems sleeping? How's your appetite? Are you eating? I mean, do you have regular bowel? Still have to answer questions that really to show that they're healthy. See where if there's anything new that I need to address. I do all that. Look at their vitals before I get into the room. So I'm doing all that before I get to them, so that by the time I get there, my chart is actually, I mean, half, completed. I found ways around it to help me because I'm able to do. I don't want to do work. I can't do twice. I mean, work twice. I can't. So, but it's very challenging, and it's not getting any easier.
I hear it a lot from the educator point of view. A lot of patients come in, they're like, I feel like my doctor is just staring at the computer the whole time. I don't think they're even listening to me. So they sometimes don't understand, the challenges from your end of having to provide care, having to document all this requirement that's placed on you. That sometimes really has nothing to do with quality of care, but you're required to do it. So they don't always understand that that's something you really need to do All they know is Dr. Daniel was just looking at a computer. I mean, you don't do that, not you in particular, but they just say their doctor's just staring and they just feel disrespected. They just feel like they're not getting the care that they deserve. So let's switch and talk about medications. I know in the community, it's a big struggle. So do you want to share your experience with having to talk about insulin as an option or even, increase in medication? What is that like, and how do you have that conversation with someone so that they understand this is the best thing for them and not something they read on the internet, where that medication might actually be necessary as part of your care?
I mean,
So, Dr. Daniel, want to go first?
that's a very good question, Vivian, and that's one of the biggest challenges we have, because one of the things I have to preach to my patients is that diabetes does not equal insulin. It doesn't mean because you're diabetic you're going to be on insulin. But when it comes to the point that they need to be on insulin, depending on what that A1C is, depending on what the blood glucose levels that we are seeing, that the patients cannot be managed by oral hypoglycemics, then we have to transition to insulin. And that's a conversation we bring the patient in and say, look, here's where we are, depending on the weight and the blood sugar and the A1C that patient has. I may just give you one shot at night. You still have to eat. You still have to follow the directions of the diabetic educators, but we're here for you. When you get up in the morning, I want you to check your sugar and see where you are. And then you're going to be checking your sugar routinely throughout the day. And then we have so many patients with diabetics, and then we have eye issues, retinal issues. So now we just list 1, 2, 3, 4, 5. It's simple. We show them where to insert in the abdomen, the abdominal wall, insulin. Just give yourself 5 units. You squeeze, and you make sure that 5 units are inserted. Then you go about your regular work. Then you eat. You go about your regular activities. Your next meal, which is breakfast, lunch, and dinner, you repeat. And I want you to check your sugar every time. That's where we get the log to come in and say, well, I need you to write your numbers down and bring them back and see me in 2 weeks. And usually once we started any one of these patients on insulin, we'll have them come back within a 2-week period. Sometimes it's 1 week, depending on the level of anxiety, because we do have a lot of anxiety. This is one that's really more time consuming for us than anything else, and especially for the guys, to tell them you have to put you on insulin. It's not an easy talk. It's not easy to break through that barrier. But that's something we just got to do patiently, sit down with them, and then once we bring them back in a week or 2 weeks with your numbers, and then we can continue.
Ms. Gwen, if you can just add more to that. I like the fact that, there is a process. You guys spend so much on education. I hear it in your voice, Dr. Daniel. There is so much emphasis on education and teaching people so when they get home, they feel like they can do this. And the fact that you have them coming in much more frequently, I think that's awesome. So, Ms. Gwen, you want to add to that?
Sure, because I've had some patients who needed to be on insulin, but have resisted and pushed back and told me no. And really, when they say no, they're not going to do it. And I've had patients who basically have, I've had to weigh down, because I'm thinking of one particular patient, and this patient happened to be a woman. She was bringing me her logs every time. If I told her to come see me every month, every 2 weeks, she would come with logs. But the A1C and the log numbers they were not on the same page at all, not in sync. And I had to go to the to the endocrinologist and speak to her about it, because the patient happened to see the endocrinologist also for thyroid disease, and the endocrinologist said she's having the same issue. The numbers are just not cohesive. They're not they're not reflective. The A1C and the log, they're just not reflective of the same person. So I actually had to find out from the patient what is underlying this. What is the problem? Why are you so resistant to adding something that can help your diabetes? Because you're on all the pills, you're still not getting any control. Oftentimes the stories that the patients tell you that they remember their mother being on insulin, and the mother had lost a toe. They're associating being on insulin with the worst of diabetes, losing a limb, losing a joint, losing something. And when I finally did with the patient, I said, okay. She was very resistant to the statement. I said, let's do this in the office. So I sat with her and I gave her the first try. Actually, we together said, let's do the first shot. And so I gave her first shot of insulin in the office. And when she had given herself the shot, her eyes popped open. She looked at me. That's it. I said, that's it. Look, you've given the 10 units of the insulin. I said, yeah. And I gave her a sample pen from her home, told her to come back and see me in 2 weeks. Let me see how she's doing. And she told me she's great. And she's been on the insulin ever, one dose of insulin ever since. But that took a lot of, patience of just counseling and educating. And, her husband was with her and everything, just to get her to realize, this is something you need. And so they're not all like that, but for some reason, a whole lot of them are like that when it comes to adding the insulin. The men especially, or because they don't like to stick their finger. Now you're talking about sticking them with a needle that's in the abdomen. However, that's another. So oftentimes those patients, we give them their first dose. Thankfully, we have samples in the office. We can give the first dose in the office. So they're with us. We're walking through the process with them, and they're realizing how simple it is. And we're dealing with the underlying issues of what you've heard, what that may be what's causing you to resist good treatment. So, but as we said, all that takes time. It's time consuming. Sometimes I think when it's oh, tired.
It is. We have the newer therapies for type 2, the injectables too. But sometimes people confuse it. They think, it's still insulin as well. So I'm glad that you guys are able to provide the first dose is right there. And they realize it's not as bad. And it's an opportunity to address the misconceptions they might have had about insulin as one of the choices in terms of managing their diabetes. People find out on internet that there is this juice or there's something that they could take to cure their diabetes, and they now think you are the enemy. You don't want them to get the good stuff. Have you heard that happen before in practice? And if so, how do you address it?
I mean, it's an ongoing thing, Vivian, and it's a good thing you said that because routinely we have patients coming in with something they've seen on the internet, and now you have TikTok and YouTube, you have everything now. So you got so many resources that patients are bringing at you to say, I heard this thing works. I heard these pills work. I heard this thing. I have this natural product that treats diabetes. And a few of them, I say, okay, treat your natural product and then come back and see me next week. Let me see what your numbers are. Right? The few patients I've done that. I've had to do that with a couple of people. The natural product, when they bring the numbers back, it never went anywhere. Then I said, let's try our natural products now, our products that we have, right? Our approved products here by the FDA, and then use those and let's see what happens. And they come back, the blood sugars are much better, right? Much better control. So I said, and I would always tell them, so I'm a young man from the Caribbean. We're from the Caribbean, so we're naturalists. I grew up drinking bush tea from my grandmother all these years. If you want to talk about natural, I know what it is, okay? But I also know that diabetes is a disease that has to be treated. So when patients are bringing those resources to me, then invariably you will see on the resources say, if you need, there's always a disclaimer there to say, hey, we're not responsible for this thing, okay?
Exactly.
So check your doctor. So that's what you have. Here's your doctor now telling you. A lady came to me one time who was diabetic and her sugars were really high. I think the A1C was around 10.2. She did not want to take anything, not even orals. She was on metformin, which she basically didn't want to take because she always read the side effects of everything. And then one day she came with a paper and said she picked this off the internet and she said, these pills right here, but she's a naturalist. She said, these are natural. She's going to take these, but these are natural, not the ones that I'm giving her. And my answer to her was, I'm sure they're natural, but I've never seen a pill on a tree. So that was my answer. So I don't understand how your pill is natural and mine is not.
Dr. Daniel, you make a very good point. And one of the beauty about practicing in DC area is that it's such a diverse community. We have people from all over the world and different beliefs, different cultures. I know same thing with me. I'm from Nigeria and Cameroon as well. And there is this belief to always want to do things a little different before we actually have to go for medication. So it is something we have to make sure, we address and doing it in a way that is respectful of people, because no matter what we say, they're convinced this is what they want to do. They are going to do it. And those commercials are always very good. They are so great in marketing these products that people really feel like this is the cure. One dose of this and all will be well. Gwen, you want to add to that your experience having to address people who want to try something else before medication? I mean, we know lifestyle is already encouraged. I'm talking about buying something off the internet they consider more natural than medications.
Oftentimes, patients will come and tell me they heard that cinnamon is a cure for diabetes or controlled diabetes. I don't know how much cinnamon. I said, how much cinnamon do you have to take? They don't know, but they heard cinnamon is a cure for diabetes. And patients will say, well, I'm doing colon cleansing because if I do colon cleansing, I'll get rid of this and I'll lose some weight. So many different things. And they're Googling and but what I really like about where we are is even though patients will do that, there are very few of them, once you have a conversation with them, that are not open to hear what you say. We, as a practice, we don't benefit from anybody's medication. When we're giving you medication, we're not invested in it. We're giving it because they've done the research to show that the medication works, and so we want to help you manage your disease. Not that we're getting kickbacks. We get nothing from any medication that comes to the office. All we write for you, nothing. And so this is to help you. When it stops helping you, we're here and we will make the change. It's becoming more and more challenging. I mean, there's no getting away from that. It's just going to get worse. But I think it comes back to the foundational. If you care enough about patients, patients will know and they will trust what you say.
I like the fact they're honest. They're going to tell you exactly what they're going to do. That's a key because sometimes people don't. You'll be telling them everything you want to tell, and they already know they're not going to do any of it. But to actually have that trusting relation where they're bringing it up themselves, they're Googling it and making sure, and being open to listening to you, I think that is great. Another thing, Dr. Dan, you mentioned a little bit of it, and it's something we see in our community where it's hard for our men to talk about is that erectile dysfunction and the fact that diabetes increase your risk for that. How do you do that? How do you have that conversation where people feel that trust that, they should bring it up because it does affect their quality of life, their relationships, and we live in a society now where that's huge. So for the men in our community, how do you want to talk to them about it? How do you open that conversation so that they're comfortable, or do you wait for them to bring it up themselves?
No, actually, when I don't, then that's actually been helping me to treat my men, the gentlemen who are coming with diabetes, because I say, hey, bro, if you don't control the sugar, trust me, that little boy down there that you've been putting so much faith in, he's gonna lose faith in you. Okay, okay. So if you're not controlling this diabetes, no matter how much you're gonna be, or you look, it's not gonna work. Okay. And with diabetes, erectile dysfunction is around the corner if you're not controlled. So that's the whole thing of trying to tell them these are so many things you can manage. That's why I say it's a systemic disease that we can live with now once we manage it. So that's the education pathway I go with. I never ever skip that part. That is critical. You get them, you get a man's attention real fast. As the providers, as the physician, it's incumbent upon us to say, hey, look, you go to where the point of maximal impact, correct?
Mm-hmm.
So whichever means you can use to get this individual to manage his diabetes, to take these medications that are so critical, right? I use that. I don't skip it for any one of my patients. I let them know. It's important. Vivian, as long as I've been practicing, it's an easy conversation for me now.
Yeah, there are a few patients in our practice right now who the ophthalmologist actually have told them that they have severe cataract and they need surgery. But because the blood sugar is so out of control in the double digits, those patients we have not been able to clear those patients for them to have their surgery, and it's been really painful. And so basically you're watching someone, really almost going blind because they're not controlling their diabetes. They're tough conversations that we are having each time we encounter these patients.
Gwen started bringing some fruits and vegetables here in the office just to give patients a sample of what they should be doing. That's been a successful event we've had here.
When you mentioned once you give people these pamphlets that have all this information on it, And sometimes it doesn't even make it past the office bathroom because it's not something they can implement when they get home. So you want to add to that?
Yeah, and oftentimes, actually, sometimes the sample foods on those pamphlets are not foods that the patients are familiar with. And often,
Preach, preach.
for example, when we look at the meal, the sample plate on one of those pamphlets, there's a salmon, a nice take of salmon on that. And the patients, so that they're like, salmon is expensive. And actually, you have to have the conversation with the patient, but it doesn't have to be salmon. Any fish, it can be a piece of chicken, but the portion size is what's important. A piece of steak, but we're looking at portion sizes. And then when we look at some of the other foods they have on there, we work in Southeast DC, and as I said before, oftentimes patients see when they think of vegetables, they really do think of canned vegetables. So it's another conversation that we have to have about just slowly changing what is healthy, and changing patients' outlook and what they eat. I'm thinking maybe one of these days, and I don't know when, we will be able to have maybe a grocery store next to us that we can partner with. When patients leave our office, basically we can refer them, like how we refer them to you, Vivian. We can refer them next door to the green grocer and have them pick up a bag of green groceries, and leave and go home. So that, because the difficulties of patients going other places where we are, we can't understate that. It's difficult for patients to move around. And so, the more resources we have close at hand, the better our patients will do.
I'm really hoping for a day when we're going to have a picture of a plate that has some jerk chicken on it, that
Yeah,
has some plantains, that has some rice and peas, and
right.
some collard greens,
Yeah,
some curry oxtail. Let's keep it real. A picture of that salmon doesn't do it in Southeast. It doesn't. It's almost an insult with
it
no
does.
seasoning. That fish just looks weird on that picture with no seasoning on it. Come on now.
I
Yeah.
agree 100%. I agree. I couldn't agree with you more, Vivian. And hopefully, pretty soon, maybe we might be onto something. We start something. How about that?
Yeah. The more we talk about it, someone will decide to come
Yeah.
and meet us where we are.
When you mention something, then it's expensive. Let's not. It's
Very-
not easy. So sometimes if we forget to mention that you can substitute for another kind of proteins, they're thinking in order to manage my condition, I have to now change
Yeah.
everything I eat, and this is so expensive. And it's like it's a non-starter for them.
Yes.
Okay.
So we
Yeah.
need more culturally appropriate materials. So I wanted to bring, as we get into the end of this podcast, I know you guys, you talk about this from your patient perspective, but I also know, this also happens in our family. We also have family members that struggle with diabetes. Is that something you have in your family as well?
Vivian, I think you're picking on us here now.
I,
Because,
oh,
I mean, our family, there's 7 of us from my mother and father, and the diabetes is coming down to the family. It started with number 1, and I think up until it's at number 5 right now, and it came in order of birth. So there's 7 of us, and there's 5 of us now diagnosed with diabetes. And I think most of them are controlled right about now, right, Gwendolyn? I think. So I'm number 6. So I'm looking at a skip here. We gotta break break this momentum at some point. I'm not sending. I'm not trying to send it to Gwen either, but I'm just figuring we just got to stop at 5.
Yeah.
But maybe we can arrest it right here and say, you know what, diabetes, you've done enough. Let's just move on.
And so it gives us more actually compassion for our patients, empathy and compassion because we actually are walking through this with, our siblings and friends around us. So it helps. It does help. We're not coming to them in just from, as provider patient, but that this also affects our family. And we're walking through similar experiences that you as a family are walking through. It helps.
we always like to end the show on a positive note. And what is 1 or 2 things you want to leave our listeners with regarding managing diabetes? Gwen, you want to go first?
I want to let my patients know that diabetes is manageable. Diabetes has been around a long time, but it is very, very manageable. Actually, there are so many new medications now. and even some that are coming up on the horizon that have been really treating diabetes. The new non-insulin injectables, I'm sure patients have heard some of them, Ozempic, Trulicity, that are really helping with controlling the A1C and helping patients lose weight. So just to let patients know that we do have resources to help you. We do care about you and this disease. We are willing to use every resource possible that we have to help you. And so partner with us. We're in this together.
For myself, I want to tell for most of my male patients, number one, diabetes does not equal insulin. Number two, diabetes does not equal dialysis, because those are the big questions that come in when we have a patient who's diagnosed. Oh, I'm going to be on dialysis 3 days a week and I'm going to be on insulin. And once you find that, you will find it much easier to manage this critical disease. It is a dangerous disease if it's out of control, but we can control it. And we have patients who are living with it for years and years and years because they have it controlled. So it is manageable.
Thank you both so much. I appreciate you joining me for this podcast. I know we're going to be hearing a lot more from you, Dr. Daniel. Gwen Daniel-Challenger, truly appreciate all the insight you provided today. And for our listeners, if you want more information, please sign up to our YouTube channel at Surrogate Health. Follow us on Instagram and on Facebook. We are going to be providing more information in the notes on how to reach Dr. Daniel, Gwen Daniel-Challenger, their practice. If you have questions for them, please submit the questions and we will make sure that we get you answers, link you up to resources out in the community that can help. We also want to hear from you. Give us feedback, suggestions for our future episodes. And we really enjoyed this. This was a really amazing conversation. And if you really like this, share with your friends and family, anyone that could really benefit from hearing this information. So thank you, Dr. Daniel, Gwen Daniel-Challenger. I am grateful.
Thank you, Vivian. See you at the next episode.
See ya.
All right. Until
Bye-bye.
next time, remember your health matters.